Well, good evening, everyone, and welcome to tonight's presentation. We're so pleased you have all joined us for this webinar about atrial fibrillation, or AFib, and are making your health a priority. I'm your host, Jenny Hawk, Senior Marketing Specialist for Franciscan Health. Our doctor has some great information to share with you this evening, and by the end of our time together, you will know more about what we mean by atrial fibrillation, a little more about heart arrhythmias in general, including differences between these conditions and heart palpitations, what kind of treatments there are for AFib, including medications, procedures, and devices, and what to do if you experience heart arrhythmia side effects. Now, before we get started, I just have a few housekeeping things to review. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have questions to ask our presenter, please type them in the chat or Q&A window at the bottom of the Zoom screen. We'll be answering your questions at the end of the webinar during our Q&A time. Our administrator, Kirsten Wachowski, is taking care of everything on the back end this evening. If you experience any technical difficulties, just type them in the chat window, describe them, and we'll work to resolve them as quickly as possible. And if you miss anything during the webinar, don't worry. We'll send a link to the recording of tonight's presentation in a follow-up email. So let's go ahead and get started. First, we'd like to know a little bit about our participants. Right now, we have about 36 people listening so far. For our first poll question, please choose the answer that best describes why you're interested in this topic. 1, I have a family member who has AFib and want to know if this puts me at risk. 2, I'm interested in learning more about heart arrhythmias and current treatment for this condition. 3, I have AFib and want to better understand the condition and my treatment options. 4, I want to learn how I can prevent heart disease in general, including heart arrhythmias like AFib. Now, more than one of these may apply to you, we realize, but please choose just one for now. All right, we have about 38% of you have picked number 3. I have AFib and want to better understand the condition and my treatment options. And 27% chose number 4. I want to learn how I can prevent heart disease in general, including heart arrhythmias like AFib. Well, thanks so much for replying to this poll question. This just kind of gives us an idea of where to take the presentation. Atrial fibrillation is the most common type of arrhythmia, and more than 2 million Americans have it. It primarily affects older adults. In fact, nearly 1 out of 10 age 65 and older have AFib. To tell us more tonight about AFib is one of our board-certified electrophysiologists with Franciscan Health Indiana Heart Physicians. Electrophysiology is a specialty in cardiology focused on the electrical activity of the heart. Dr. Philip George Jr. is a graduate of the University of Miami School of Medicine. He served his internship in internal medicine at the University of Florida in Gainesville, a fellowship in cardiology at University of South Florida, and went back to the University of Florida for a fellowship in electrophysiology. And he has been with Indiana Heart Physicians now for several years. So, Dr. George, welcome, and thank you for presenting tonight. Kirsten and I will turn the program over to you now.
Well, thank you for that introduction, and I want to thank everybody for joining online. So I'm going to share my screen here. And hopefully everybody can see that. All right, so the title of today's talk is called Feeling Butterflies, and of course we're going to be focusing on atrial fibrillation. Again, this is sort of interactive, so if you have questions, please be sure to put those in the Q&A or the chat box so we can go over those at the end of the slide deck. All right, so to start off, what is atrial fibrillation? So it's a disorganized rhythm that occurs in the atria. And when we talk about cardiac anatomy, the heart has four chambers. The top chambers are the atria, the bottom chambers are the ventricles. And so atrial fibrillation refers to an abnormal disorganized rhythm that's occurring in those top chambers. And so we generally classify it as an irregular rhythm. But one important distinction is that not all irregular rhythms are atrial fibrillation. The reason I bring that up is because sometimes if folks are at home and they're checking their pulse, sometimes you may feel that your pulse is a little irregular, and just because it is doesn't necessarily mean that you're in atrial fibrillation. It of course could mean that you're in atrial fibrillation, but again, the key is to remember that not all irregular rhythms are AFib. And apart from that, sometimes patients will come to clinic and say, hey, check my blood pressure. My blood pressure cuff indicated that my heart rhythm was irregular. Could I be in atrial fibrillation, or could I have had atrial fibrillation? And again, there's no way to know for sure just based on the irregularity of the rhythm, because that's not how we diagnose it. But again, that is one of the clues to sort of tip us off that somebody could be in atrial fibrillation if that rhythm is irregular. We do consider atrial fibrillation a chronic medical condition, and the reason for that is that there is no cure for atrial fibrillation. But that being said, we consider it sort of a medical condition that can be adequately treated and stabilized, and something that you can live with lifelong, where it doesn't really have a significant impact, hopefully, on your quality of life. All right, so what contributes to atrial fibrillation? Well, there are a whole host of things that can contribute to them, or to the development of atrial fibrillation, and I've listed some of them here. Of course, if patients have underlying heart disease, that is always a potential contributing factor. So patients, if they have a history of heart failure, if they have underlying coronary artery disease, that can also be a contributing factor. We say high blood pressure or underlying valve disease can contribute as well. Particularly mitral valve disease. Patients have significant disease, particularly on the left side of the heart, where we have the mitral valve. Patients can be at risk for developing atrial fibrillation. And some of these things also run together. So patients, if they're obese, if they have sleep apnea, those two things can sometimes run together. And so obesity and sleep apnea can sometimes be a trigger for patients developing atrial fibrillation. Apart from that, we say thyroid disease can sometimes do it, and alcohol can as well. And that's important to sort of note, because we do have patients that like to enjoy a glass of wine every now and then, or a beer every now and then. And so it is important to realize that that can be a trigger for some individuals. And if it is for a particular patient, then sometimes cutting back on those particular triggers can help modify in a positive way the burden that atrial fibrillation that patients have. Apart from that, we say that stimulants can contribute as well. So, folks obviously consume a lot of caffeine, coffee, foods, right, chocolate, and the like. And so stimulants like caffeine can be a trigger for atrial fibrillation, particularly in high quantities, in the amount of caffeine that most individuals consume on a regular basis. Typically wouldn't expect it to be a significant contributor, but if you're having like 15 cups of coffee a day, then it could be an issue. Energy drinks, of course, and especially this time of year as individuals are getting sick, they're coming down with the flu or, other viral illnesses. If you're taking over-the-counter medications, decongestants, sometimes those medications that you get over the counter can contain stimulants that can actually trigger atrial fibrillation. Apart from that, we say any physiologic stress can really trigger atrial fibrillation. So sometimes when we see patients in the hospital, they're coming in for scheduled surgery, have never had a history of atrial fibrillation, and then after surgery, all of a sudden, they go into atrial fibrillation. And in much the same fashion, patients, when they come in, if they have a really bad infection or illness, that can sometimes trigger them to go into atrial fibrillation for the first time. And electrolyte abnormalities can as well. So again, a whole host of things that can contribute to the development of atrial fibrillation. And it's important to sort of keep those things in mind, because sometimes if we can sort of identify a particular trigger for a patient, if we address those potential triggers, then we can, like I said, modify in a positive way the burden of atrial fibrillation that patients have. Right, so how do we make the diagnosis, right? I said before, beginning of the talk, that atrial fibrillation is an irregularly irregular rhythm, but not all irregular rhythms are atrial fibrillation. So we make the diagnosis by either getting an EKG or some sort of telemetry monitor. And so I made the note here that, especially now with the advent of some new and pretty sophisticated technology, smartwatches and personal ECG readers, they can give you an ECG strip that can sometimes indicate that a patient may actually have atrial fibrillation. The reason I say that it can suggest but not make the diagnosis is you usually want to make sure that somebody with a medical background, right, a physician, is actually looking at those strips to sort of adjudicate it and determine whether it is or is not atrial fibrillation, because there are instances where, as good as these devices are at detecting atrial fibrillation, sometimes they will make mistakes. And so sometimes we will get some false positives where it indicates that a patient has had or is having some atrial fibrillation when in fact that is not the case. So you always want to make sure that somebody with a medical background is reviewing that. But these devices are pretty sophisticated. They oftentimes will, get the diagnosis correct. But sometimes there will be false positives. And so how do we make that diagnosis? And so I'll sort of go over that with you, and hopefully you can see my arrow here. But if you look at this strip here, it says sinus rhythm. If you look at the bottom strip here, you can hopefully appreciate that if you see these narrow deflections here, if you were to just sort of visualize, you can sort of maybe appreciate that the distance between these deflections is pretty similar. It's pretty regular. And if you notice that prior to those deflections, those sort of tall, narrow deflections, you have smaller, lower amplitude deflections. And those smaller, lower amplitude deflections actually signify atrial contraction. So this particular patient is in sinus rhythm. And so when patients are in sinus rhythm, you have one atrial contraction for every one ventricular contraction. So that's actually what you're seeing here, is you see atrial activity as indicated by that small, lower amplitude deflection. And then you see ventricular activity or contraction indicated by that taller, narrow deflection. And so again, for every one atrial sort of impulse, you have one ventricular contraction. And so you can see that here throughout, is that prior to each of those deflections, you have a small lower amplitude deflection. And again, this patient here, this bottom strip is in sinus rhythm, where if you contrast that to the strip up top, that patient is in atrial fibrillation. And so maybe what you can appreciate in sort of comparing these two strips is, one, that this strip is pretty irregular. So if, again, you were to look at the distance between each of these deflections, the distance from here to here and from here to here, you can appreciate that there's some variability, right? So this patient is in an irregular rhythm. And then apart from that, in contrast to this strip below, where the patient is in sinus rhythm, and you have these sort of well-inscribed low amplitude deflections, you don't really see that here. Prior to each of these tall, narrow deflections, you don't really see that smaller low amplitude deflection. And that is how we make the diagnosis of atrial fibrillation. So you don't see those smaller deflections, you see an irregular rhythm, and oftentimes the rhythm or the rate is going to be pretty fast. And so again, the ECG or some sort of telemetry monitoring is going to be the key to making the diagnosis. Now, again, having an irregular rhythm may clue you in to having some atrial fibrillation, but again, the only way to know for sure is to get some sort of ECG, right? So what are the effects? So when patients go into atrial fibrillation, the atrial rate is oftentimes going to be very, very elevated. So patients that have atrial fibrillation, their atrial rate can exceed 300 impulses per minute. So that is very, very fast. So you have all of these atrial impulses that are trying to stimulate that atrium. And a lot of those impulses also make their way down to the bottom chamber of the heart, the ventricle, and actually drive that ventricular rate up. So the thing that really drives, or sort of, I would say the thing that drives our ventricular rate, our heart rates, are what is happening in the atrium. So when patients go into atrial fibrillation, when you have an excess of these atrial impulses, that can cause the ventricular rate or the heart rate to increase quite rapidly. So not uncommonly, when patients go into atrial fibrillation, their heart rates at rest are going to be elevated. So if you're in a normal rhythm, and we'll call sinus rhythm, resting heart rates sometimes will be anywhere between, say, 50 beats a minute at rest to 100 beats a minute at rest. But when patients go into atrial fibrillation, their resting heart rates can be 120 beats a minute or 130 beats a minute at rest. And so that's because, right, atrium is sending all of those electrical impulses down to the bottom chamber of the heart. And those impulses are conducting down through a portion of the conduction system called the AV node. Reason we call it the AV node, it's an abbreviation. It stands for atrioventricular node, and it sits between the atria and the ventricles. And that's where those impulses are sort of making their way through to stimulate that bottom chamber, that ventricle. And so when we try to regulate and treat atrial fibrillation in a number of patients, one of the things that we'll do is we'll actually initiate medications to help slow or block some of those impulses so we can slow that ventricular rate down. Now, in addition to having sort of high heart rates, when the atrium is in fibrillation, you actually lose coordinated atrial contraction. Right? And so when that happens, some patients can actually feel the sensation of palpitations. And so what exactly are palpitations? So when we say palpitations, essentially what we're referring to is the sensation of your heart beating. In the same way that when you blink, you typically aren't going to feel that. You just sort of do it, right? And, and you don't even really think about it. It's just happening all the time. Same thing, right? Most of the time, right? Your heart's beating normally, you're not going to feel it. But when patients go into these abnormal heart rhythms, particularly atrial fibrillation, you can sometimes feel the sensation of your heart beating sort of erratically and irregularly. And sometimes patients will sort of report that they feel sort of butterflies in their chest. And so that, of course, is why, right, the talk is titled Feeling Butterflies. And with that loss of coordinated atrial contraction, that actually causes essentially some inefficiency in how the blood is being pumped through that atrial chamber. And because of that sort of lack of efficiency, clots can actually form in the atrium. And if clots form in the atrium, if those clots were to migrate, they can sometimes block arteries in the brain and lead to stroke. But those clots, if they were to migrate, they can block arteries in any organ system and cause downstream effects to that potential organ system. And so one of the ways I would sort of try to describe it is if, you were trying to take, a slow, deep breath, over the next 5 seconds, you may take 2, large, deep breaths. But if I told you to take 100 breaths over the next 5 seconds, you wouldn't be able to take very deep breaths. You would have to take very quick, shallow breaths, and you're not really going to be able to move air efficiently. And the same thing is true in the atrium. When patients go into atrial fibrillation, blood is not moving efficiently in that atrium. You can get stasis where blood is sort of a little bit more stagnant, and that's where clots can form, and that's what patients can have strokes. Right. So what are the symptoms that patients can feel, right? So again, with regards to the title of this talk, Feeling Butterflies, Palpitations, right? That's one of the things that patients can report. But just because you feel palpitations doesn't necessarily mean that you have atrial fibrillation. Patients can feel palpitations for other abnormal, not necessarily dangerous heart rhythm disturbances. So it's not a specific symptom. They're somewhat non-specific, and much like that, fatigue, shortness of breath are sometimes symptoms that patients can commonly associate with atrial fibrillation. Again, also not specific. So patients can have those symptoms and not have atrial fibrillation. Some patients, when they go into atrial fibrillation, they can have a propensity to retain fluid, develop heart failure symptoms. Some patients will report dizziness and lightheadedness associated with episodes of atrial fibrillation. And sometimes patients can actually have blood pressure changes. So some patients will report their blood pressure sometimes will drop when they go into AFib. And there are some patients that actually have their blood pressure actually rise a little bit when they go into atrial fibrillation. So again, there are a number of different things that patients can report. Not any one thing is specific for atrial fibrillation. But the other thing that's also important to note is some patients actually have no symptoms associated with atrial fibrillation. So those patients, if they get diagnosed, they're usually diagnosed incidentally, meaning that they're seeing a physician for some other reason. They're, at their primary care physician's office for a wellness check, and, they get examined, and then the physician determines, hey, I think you're in atrial fibrillation, and then they get the EKG to confirm that, right? Or patients in the hospital to have a procedure, and, they hook them up to a monitor, and then all of a sudden, right, we determine that that patient has atrial fibrillation, despite the fact that the patient has no symptoms associated with it. So again, some patients do have symptoms, some patients are completely asymptomatic. Right, so what are the impacts of atrial fibrillation? So one of the key things here on this slide is that, or one of the sort of take homes is that, as we age, the risk of developing atrial fibrillation increases. So if you look at individuals under the age of 60, less than 1% of individuals under the age of 60 will have atrial fibrillation. But as we age, get older, right, 75 to 84-year-olds, about 12%. And there's some, different data here based on different papers, but right, patients greater than 80 years of age, about 33% of those patients can have atrial fibrillation. And then as far as morbidity and mortality, right, I'd already sort of mentioned that stroke is one of the biggest negative associations with atrial fibrillation, with an almost 5-fold increase in the risk of stroke. But patients, again, with atrial fibrillation, some of them have a propensity to retain fluid and develop heart failure symptoms. Not all, but some patients can develop heart failure symptoms. And some patients, again, have no symptoms. They have no issues with fluid retention, doesn't impact their quality of life, their cardiac function. And then there are some patients that can have a 2-fold increase in the risk of developing dementia because of underlying atrial fibrillation. So it's not an imminently dangerous heart rhythm where if you go into atrial fibrillation, something terrible is going to happen in that moment. But right, it is a chronic medical condition, and having atrial fibrillation unfortunately does predispose individuals to developing or having some of these issues down the road. Right. So apart from that, right, there are some very real financial implications. So right, nearly 500,000 hospitalizations per year. And quite a substantial cost of the healthcare system. We say anywhere from $26 to $28 billion are spent annually dealing with and treating atrial fibrillation. All right, so how do we classify it? So, as it relates to patients, this may not be entirely relevant, but as physicians, we like to try to classify atrial fibrillation. And there's a reason for that, and I'll sort of go into that on the next slide. But we classify it in a number of different ways. And so you may hear the term paroxysmal atrial fibrillation, and that refers to patients that have atrial fibrillation that terminates generally within 7 days. It usually spontaneously terminates in these individuals. So some patients will tell you, yeah, I have AFib, and I'll go into it for a few hours, and then it'll sort of resolve on its own. And so those patients we classify as paroxysmal. Then you have patients that generally tend to have more sustained episodes. We call those patients persistent atrial fibrillation, usually with episodes lasting longer than 7 days at a time. If patients have been in atrial fibrillation for over 12 months or for over a year, we consider those patients or classify those patients as having long-standing persistent atrial fibrillation. And then sort of fourth classification is what we call permanent atrial fibrillation, where we leave some patients in atrial fibrillation, and those are the patients that don't have symptoms associated with atrial fibrillation. They feel well, right? It's not impacting their quality of life, doesn't impact their cardiac function or what they're able to do, right? So those patients, we just leave them in atrial fibrillation. So those patients we classify as having permanent atrial fibrillation. Now, another classification that you may have heard of, probably on TV, I know you've probably seen a lot of advertisements for some of the blood thinners and some of the appendage occlusion devices on TV, but they'll sort of talk about what's called valvular versus non-valvular atrial fibrillation. And so non-valvular atrial fibrillation refers to atrial fibrillation that's not associated with essentially valve disease, particularly the mitral valve. So patients don't have a history of mitral stenosis. They don't have a history of valve surgery or valve repair, including mitral valve repair. Those are the patients that are deemed as having non-valvular atrial fibrillation. And the reason that's relevant is because some of the things that we offer to patients, whether it be procedures or blood thinners that are recommended, are largely dependent on whether patients are classified as valvular or non-valvular atrial fibrillation. And most patients are going to fall into the category of non-valvular atrial fibrillation. All right, so again, why is this classification important, right? So the reason that classification is important, particularly for physicians, is because there's this saying that atrial fibrillation begets atrial fibrillation. And the longer that a patient spends in atrial fibrillation, the longer a patient is in AFib, the harder it is for us to get those patients out of atrial fibrillation. So we say that the more AFib that an individual has, the more predisposes them to atrial remodeling. And what I mean by that is that the atrial architecture starts to change over time, and that atrium actually starts to favor atrial fibrillation. So, if I were to see two patients in clinic and one patient's been in atrial fibrillation, let's say for 6 months, consistently, right, every day for the last 6 months, and they want to talk to me about trying to get back in a normal rhythm, whereas you have another patient that I see maybe later that same day that's been in atrial fibrillation every day for the last 6 years, right? If I were to have a discussion about the odds of getting those patients back in a normal rhythm, the odds of getting somebody back in a normal rhythm and keeping them in normal rhythm more durably would be better in somebody that's had less atrial fibrillation, as opposed to, say, somebody that's been in it every day for the last 6 years. Again, the longer you're in it, the more likely you are to stay in it, and the odds of us getting you out of atrial fibrillation are lower. And that's not to say that we can't try, but we do tell patients, right, that these classifications are important because it helps us sort of determine who are the patients that are generally going to do better than others, depending on, again, the chronicity of their atrial fibrillation. Right. So what about atrial flutter? I know that the talk is really focusing on atrial fibrillation, but in some of you that either have a history of atrial fibrillation or know somebody with atrial fibrillation, you may have also heard the term atrial flutter. So what exactly is atrial flutter? Well, it is a different and distinct rhythm from atrial fibrillation. And patients that have atrial fibrillation can also have atrial flutter. And the converse is true. And so patients, there can be some overlap. There are some patients that generally only have atrial fibrillation. They never have atrial flutter. And there's some patients that only have atrial flutter and they never have atrial fibrillation. And there can be, again, some overlap between the two. And generally speaking, these rhythms are treated the same way. So patients that have atrial flutter are oftentimes on the same regimen of medications as patients that are in atrial fibrillation. And patients that have atrial flutter and atrial fibrillation can oftentimes have very similar symptoms. Now, one of the sort of key distinguishing features is if you look at the ECG, and again, I've got some strips here that hopefully you can appreciate. Again, this is the strip that we looked at earlier. And if you look at this strip, again, the rate is pretty irregular, and you don't really see any clear atrial activity, right? As we saw that patient that was in sinus rhythm that had that small, low amplitude deflection that preceded these tall, narrow deflections. Whereas in the patient that has atrial flutter, right, you can see there's some well-inscribed small, low amplitude deflections, right, that sort of give this appearance of a sawtooth. And so that is what we look for in patients that have atrial flutter. And the reason that we make this distinction, not so much from a medication standpoint, because again, medically, patients are oftentimes on same therapy or similar therapy. But the reason we make this distinction is because if we are going to do procedures called ablations, where we try to get patients out of these rhythms, we want to know where to take our catheters or where to do our procedures, because these rhythms occur in different areas of the atria. So atrial flutter is more of a right-sided rhythm disturbance, whereas atrial fibrillation is more of a left-sided rhythm disturbance. So if a patient is undergoing an ablation for atrial flutter, they'll typically have an ablation in their right atrium, whereas if a patient is having an ablation for atrial fibrillation, they'll have an ablation in their left atrium. So again, that's why it's important for us to know anatomically, or at least make that distinction based on the EKG, because if we are going to do any procedures, we want to make sure that we're working in the correct chamber. All right, so how do we manage atrial fibrillation? Well, so two of the things that we look at, one of the first things we assess is, what is an individual's risk of stroke? And the second thing that we assess is what are a patient's symptoms? So how do we determine an individual's risk of stroke is dependent on what we call the CHADS-VASc score. And so that's this sort of risk stratification score that we use to determine if patients are at an elevated risk of stroke or if they're at a low risk of stroke. And it's a mnemonic, and it basically, the C stands for CHF or congestive heart failure, the H stands for hypertension, the A stands for age, D for diabetes, S for stroke, vascular disease, and then we say gender or sex. And so if patients have a score of 2 or greater for men, then those individuals should be on a blood thinner based on guidelines. And for women, if women have 3 or more of those risk factors based on guidelines, then those women need to be on anticoagulation. If you have less than those number of risk factors than on guidelines, you actually don't need to be on anything, but some physicians will actually prescribe aspirin, and that used to be sort of the mainstay of therapy years ago, and that's oftentimes even prescribed currently, but more recent updated guidelines are sort of shying away from the use of aspirin, particularly in low-risk patients. It's really, again, if you have the risk factors for stroke, then you really should be on a full blood thinner, and aspirin really isn't going to cut it. But that being said, there are some physicians, including myself, that will sometimes give aspirin to patients. But again, guidelines are sort of shying away from them. So we are operating a little bit outside of guidelines when we do that. But again, not uncommon for us to see that in patients that have a low risk of stroke. Now, again, the second thing that we always try to assess is whether or not patients have symptoms associated with their atrial fibrillation, right? Because again, you can have patients that are completely asymptomatic, and then you can have symptomatic patients. And in the patients that are asymptomatic, it is reasonable to keep those patients in atrial fibrillation, but just make sure that their heart rates are adequately controlled. So if you control the heart rates in those individuals, oftentimes those individuals do pretty well. They don't have any symptoms associated with it. And again, they can essentially stay in atrial fibrillation without us trying to get them back in a normal rhythm. And that's a reasonable management strategy. Whereas in patients, if they have symptoms associated with atrial fibrillation, then we can oftentimes try to get them back in a normal rhythm with what's called a rhythm control strategy, where we try different things to try to maintain normal rhythm, whether that be a medication or ablation. And there are a number of patients that can be symptomatic when they're in atrial fibrillation, but particularly if their rates are not well controlled. So some patients, if you control their heart rates, they have no symptoms associated with AFib, despite the fact that they're still in it. And it's reasonable to keep patients in atrial fibrillation as long, again, as their heart rates are adequately controlled and they don't have symptoms. So again, we try to determine whether patients have symptoms or no symptoms, and that really sort of helps us guide management options for atrial fibrillation. Right, so we can probably go to this poll question, right? So which of the following is true regarding atrial fibrillation, right? 1, medications are curative for atrial fibrillation. Cardiac ablation procedures are curative. Medications and ablation are necessary to cure atrial fibrillation, or none of the above. There is no cure for atrial fibrillation. So if you want to just take a few seconds to go through those options and pick your best guess, and then we can go to the next slide. All right, I'm going to go to the next slide, and that's going to reveal the answer. Perfect. Everybody did great, right? So there is no cure for atrial fibrillation, right? So atrial fibrillation, again, we consider it sort of a chronic medical condition. In patients that have atrial fibrillation, there are a number of things that we can do to get patients out of atrial fibrillation, but the goal of doing those things is to try to minimize the burden of recurrence, right? And so ablation and medications can be effective at minimizing that burden, but neither is curative. Now, that being said, there are some patients that'll tell you, hey, once I started this medication, it cured my AFib. I never had any more AFib. And for some patients, that may be true. And some patients will also tell you, hey, I saw this physician, they did an ablation on me and I did great. It cured my AFib. I haven't had any more since the ablation. And for some patients, that may be true. But on the whole, we can't guarantee that anything that we do, whether it be initiating a medication or even doing an ablation procedure, is going to prevent somebody from having some recurrence later down the line. And there's a reason that that's important to sort of realize, and we'll sort of go into that a little bit later here. Right? So is anticoagulation necessary, right? So largely depends, again, on that CHADS VASC score. Again, we determine based on an individual's risk factors whether or not they should or shouldn't be on a blood thinner, right? So if that score is elevated, then the recommendation per guidelines is to be on lifelong anticoagulation, right? And the reason for that is there is no cure for atrial fibrillation. If one day we can cure AFib, then maybe we will be able to get patients off of anticoagulation. But until that happens, if you are diagnosed with atrial fibrillation, if you have risk factors for stroke based on that CHADS VASC score, then you should be on anticoagulation. And it's important to know that the need for anticoagulation is not dependent on the burden of atrial fibrillation. So what do I mean by that? So guidelines don't make the distinction between whether somebody's in atrial fibrillation for, let's say, 1 week out of the entire year, or they're in atrial fibrillation for 7 months out of the entire year. So guidelines don't say somebody's in it for a week, their risk of stroke is less, so they don't need to be on a blood thinner, whereas somebody that's in it for 7 months out of the year, their risk of stroke is higher, they need to be on it. Guidelines basically revert back to that CHADS VASC score. Do you have enough risk factors for stroke, regardless of the burden, whether it's 1 week or 7 months, right? Guidelines say if you have the risk factors, then you should be on it indefinitely. Now, in some instances, if a blood thinner is relatively contraindicated, then sometimes patients can be considered for what's called an appendage occlusion or ligation procedure. So that could be considered in patients that are not felt to be good candidates for long-term anticoagulation. And as far as anticoagulation is concerned, there are a number of different medications that will prescribe, some of which you're probably familiar with or have seen ads on TV. Probably oldest tried and true medication is warfarin or Coumadin. Then, of course, there's Eliquis, Savasa, Xarelto, and Pradaxa. Those are the medications that are used to thin the blood to reduce that risk of stroke in patients that have atrial fibrillation. And then there's what are called these appendage occlusion devices, one of which is called a Watchman. You may have seen ads for that on TV. There's another device called the Amulet. Again, you may have seen ads for that on TV. And then there's a procedure that surgeons will sometimes do, and that's called an AtriClip. So I'll sort of go into that briefly here. All right, so these are the anticoagulation alternatives, right? So atrial appendage occlusion. So the atrial appendage is a small outpouching, and if you can see in this diagram here on the right, there's a small little outpouching, and that outpouching is sort of circle there, and that outpouching is where clots form typically in patients that have atrial fibrillation, and that outpouching is called the appendage. And so what a physician does when they do these procedures is they occlude the appendage either with what's called a Boston Scientific Watchman, and that's just the company that manufactures this device. So basically they deploy this Watchman device in the appendage, it occludes the appendage, or they implant what's called an Abbott amulet, and that, of course, is just the company that manufactures it. And it's sort of a similar device that occludes and blocks that appendage. And if you can block that appendage, you can reduce the burden of clot that patients are liable to form in atrial fibrillation. And eventually, those patients can come off of a blood thinner and just remain eventually on just an aspirin. And then what the surgeons do is they can do what's called an AtriClip, and they have this nifty little device here that they use to essentially put a clip that essentially pinches off the left atrial appendage. And this is something that is done with a surgeon, and it's a little bit more invasive than either the Watchman or the amulet procedure. So those procedures, the Watchman or the amulet, those are done, we say percutaneously, where a physician essentially will get access to a blood vessel in the leg, and through that blood vessel, through that vein, they'll advance the delivery system up to the heart. So when they're done, what they'll do is they'll pull the catheter. Won't have any, major, cuts, or you don't have to do any open heart surgery to do this procedure. It's just a small catheter in the groin. And that's how those devices are delivered. Whereas when a surgeon puts in an AtriClip, they actually have to make an incision in the rib and get access to the heart that way. So it is a little bit more invasive, and there's some reasons why an AtriClip may be a better option for some patients as opposed to a Watchman or an amulet. And sometimes the surgeons will actually do it at the time of open heart surgery. So if a patient is undergoing bypass surgery for coronary artery disease, or if they have valve disease and are undergoing valve repair, sometimes at the time of surgery, when a surgeon is already working on the heart, right, they're already in there, they'll go ahead and put that clip in. All right. So as far as management is concerned, again, how do we manage patients? There are two strategies. One is what we call a rate control strategy, and the other is called a rhythm control strategy. And so when do we choose a rate control strategy? Well, again, that largely depends on symptoms. So if patients have symptoms that are predominantly driven by poorly controlled heart rates, if we can adequately control those heart rates and the patients have no symptoms, then it's a reasonable approach to choose a rate control strategy. And the way that we do that is by using medications. Those medications will, again, work on the conduction system of the heart, where they slow those heart rates down, where they block some of those impulses from conducting down to the ventricle, and help slow that rate down so that patients feel better and do better despite the fact that they are still in atrial fibrillation. Now, in some instances, despite our best attempts to get patients well rate controlled with medications, it just does not work. We sort of throw the kitchen sink at patients. We put them on every medication at high doses, and it's just not enough to get patients adequately controlled. Well, sometimes we may have to consider putting in a pacemaker and doing what's called an AV node ablation. And that's a procedure that allows the pacemaker to then dictate and control the heart rates. And it doesn't eliminate an individual's atrial fibrillation, but it just prevents that atrial fibrillation from causing the heart rate to be poorly controlled. Right. And so the next sort of option, right, apart from rate control strategy, is a rhythm control strategy. And when do we choose that? Again, it depends on symptoms. So patients who we determine have symptoms associated with underlying atrial fibrillation. So irrespective of whether or not the heart rates are controlled or not well controlled, patients still feel worse when they're in atrial fibrillation, then those are the patients we want to try to get back into normal rhythm. And so if we can get patients back into normal rhythm and get them feeling better, we want to try our best to do that. And how do we do that? Well, there are a number of ways. One is to do what's called a cardioversion. And again, if you have AFib or no family members or friends that have it, this is something that may have been done to them in the past or may have been discussed at some point. And this is when we essentially deliver electrical energy to sort of reset the electrical system of the heart. It's similar to what you've probably seen on medical dramas on TV, where they put paddles on a person's chest and they say clear, and they sort of shock somebody out of an abnormal heart rhythm. It's less exciting in real life, but that's essentially what we do in those circumstances, is we do that cardioversion to try to get somebody back into normal rhythm. It's oftentimes effective in the short term as far as getting patients out of atrial fibrillation back into normal rhythm. But again, it is not curative, and it doesn't prevent patients from having recurrence. The two things that really prevent recurrence of atrial fibrillation are using medications or considering an ablation. So again, there are certain medications that we use that are specifically geared to help keep patients in normal rhythm. And so we can use those medications to help maintain normal rhythm in some patients. And again, some patients may have told you, hey, I started this medication, I did great, it cured my AFib. Again, we cringe when patients say that because we know it's not a cure, because there's always a chance it could recur. But those medications, again, help keep patients in rhythm. And sometimes, again, we have to consider an ablation procedure. And that is a minimally invasive catheter-based procedure where much like that Watchman procedure or that amulet procedure, we insert catheters in the blood vessels in the leg or the groin. We advance those catheters up to the heart, and we target the areas of the atrium that are responsible for causing atrial fibrillation. When we do an ablation, essentially what we are doing is we are creating scar tissue in the heart. And it seems a bit odd for us to do that, but if we can create scar tissue in targeted areas of the heart and do it, in sort of a pragmatic way where we're not just ablating everything, then patients can do pretty well. And that has been shown to reduce the burden of atrial fibrillation that patients have. And so when I sort of explain this to patients, I say it's sort of like, patients, if they're being treated for cancer, for example, they're getting chemotherapy, oftentimes chemotherapeutic agents, they can not only injure cancer cells, which is the intended purpose, but they can also sort of damage healthy cells, right? And you sort of take the good with the bad. And the same is true with atrial fibrillation. When we're doing an ablation, we're rendering certain areas of the atrium electrically inactive. And if you can do that in certain areas without going too crazy and ablating too much, again, you can reduce the burden of atrial fibrillation that patients have. Now, again, certain physicians can do that through a minimally invasive catheter-based procedure, and surgeons can also do ablations as well. But much like that AtriCure or AtriClip procedure I was telling you about before, that tends to be a little bit more invasive. And sometimes there are good reasons why that may be a better option for a particular patient. But ultimately, the process is the same, where they are using a specialized ablation system to create scar tissue in the heart. And that scar tissue acts as an electrical barrier, and it prevents some of these spontaneous electrical impulses from triggering these rhythm disturbances. And again, that's been shown to be pretty effective at minimizing the burden of atrial fibrillation that patients have. Now, when we talk about the different types of ablation, there are a number of ablations that can be offered to patients. Historically, the two types of ablations that were previously performed, what were called radiofrequency ablation and cryoablation. And these are sort of thermal ablations. And essentially what you're doing is you're ablating in certain areas of the atrium, and you're either heating the tissue with radiofrequency ablation to render that tissue electrically inactive, or you're cooling that tissue to very cold temperatures, almost like frostbite, where you're creating that scar tissue to render certain areas of the atrium electrically inactive, and thereby reducing the burden of atrial fibrillation that patients have. Now, with thermal ablation, there is the potential for some collateral injury. So whenever we talk about invasive procedures, we talk about the risks and, of course, the benefits. But as far as the risks are concerned, as it relates to thermal ablation, there's a small risk of injury to the esophagus, which sits behind the atrium, and there's also a small risk of injury to the phrenic nerve. The phrenic nerve is the nerve that innervates the diaphragm, and the diaphragm is the muscle that allows the lungs to inflate and deflate. And so in patients undergoing radiofrequency or cryoablation, oftentimes when we talk about the risks of those procedures, we'll mention the risk of potential esophageal injury or phrenic nerve injury. And so I will tell you, despite the fact that those things can happen, the risk of those injuries, fortunately, are pretty low, generally less than 1%. So even though it can happen, it's pretty rare that it does. Now, there's a newer type of ablation that recently is being performed at centers throughout the US and even internationally, and that's what's called pulsed field ablation. And so that's different than these thermal types of ablation, where you're either heating the tissue or cooling the tissue to create scar tissue. With pulsed field ablation, what you're doing is you're delivering a high amount of electrical energy, high amount of voltage over a very short duration of time, on the order of milliseconds. And that has been shown to also create scar tissue in the heart, but it's also been shown to be more cardioselective or cardiac selective, meaning that there's a smaller risk of collateral injury to nearby structures. So the risk of injury to the esophagus or phrenic nerve, even though it's low for thermal ablation, right, less than 1%, it's even lower for pulsed field ablation. So pulsed field ablation, newer technology that's being offered centers throughout the US, again, been shown to be fairly effective and also a little bit safer than radiofrequency ablation or cryoablation. But that's not to say that radiofrequency and ablation and cryoablation are not safe. We do those routinely. Outcomes generally are pretty good, and the risks, again, of those complications generally pretty low, less than 1%. The same is true with pulse field as well. All right, so in summary, with regards to atrial fibrillation, again, it is a very common rhythm disturbance. It is not imminently dangerous or life-threatening. And again, we have plenty of patients that are in atrial fibrillation 24/7. It does not bother them. It does not impact their quality of life, right? It does not impact their cardiac function. And it is reasonable to keep patients in atrial fibrillation as long as they don't have symptoms, as long as they're well controlled. And in much the same way that we consider diabetes a chronic medical condition, if you're on good medical therapy, you can keep it right well controlled, you can keep it at bay. Same is true with atrial fibrillation. Unfortunately, there is no cure, but there are several different things that we can offer patients, right, to help minimize the burden of atrial fibrillation that patients have. And those are the things that we'll typically, discuss in patients that have symptoms associated with atrial fibrillation. Again, there are different management strategies that are available. And again, because there is no cure, the goal of treating atrial fibrillation should really be to reduce the burden and really improve an individual's quality of life. And so I think with that, sort of the end of our talk, those are some of the references if you want to look those up later. And then with that, hopefully we can take some questions.
Yes, thank you, Dr. George, for that presentation. Yeah, I liked I appreciated some of the phrases used about reducing the burden of atrial fibrillation and looking at it like diabetes, that you can't cure it, but you can, find ways to control it. I really appreciate that kind of explanation. Okay, everyone, if you have a question, please put it in the Q&A. We have a few questions queued up here already. One of them is AFib inherited? My father had it and eventually had a stroke even on warfarin.
Yeah, so that's a good
There's
question.
two
I actually didn't, I did not mention that in my slide deck, but yes, there is a component of atrial fibrillation that can be genetic. So some patients may have a genetic predisposition to developing atrial fibrillation. But what I will say is that with some of the other sort of triggers or associated risk factors for atrial fibrillation, those generally tend to be more common as far as patients having atrial fibrillation. But I will tell you, yes, there is a genetic component, and some patients may be predisposed based on their family history, much like a lot of conditions.
All right. Next question, is there any correlation between developing AFib and the COVID vaccines?
Yeah, so that also a very good question. I will tell you anecdotally, right, there have been some cardiac associations with regards to the COVID vaccine. Probably the most notable is that, right, some individuals unfortunately develop some myocarditis associated with getting the vaccine, but there are some individuals that, at least anecdotally, have gone into atrial fibrillation for the first time after getting the COVID vaccine. And so we've had some clinic patients that'll report that. And then there are some patients that have a history of atrial fibrillation that are generally well controlled. And then after they get the vaccine, then sometimes they'll report, an increased incidence in the burden of atrial fibrillation that they have. But again, this is anecdotal, as far as the association with the COVID vaccine. I wouldn't say that there's a strong correlation between the two, but anecdotally, some patients will report that, and we have seen that in some of our patients.
All right. Yeah, I have a few people, I think, have questions about the palpitations. One person says she's been told he has a skipped beat, told not AFib. And another person says they feel pinpricks in their chest. It seems to happen when I eat carbs and then exercise, or when I eat carbs and drink wine. Is this prickly sensation atrial fibrillation, or is it some kind of heart arrhythmia?
Yeah, so So I guess the short answer is we don't know for sure. The only way to be absolutely sure is to see if, your physician, or if you happen to have a cardiologist, can order essentially a wearable rhythm monitor that you wear for, either a few days or sometimes even a few weeks. And over that period of time, when you have those symptoms, you can sort of indicate on the monitor, when you're having those symptoms, and we can see if it correlates with anything consistent with atrial fibrillation, or if it actually correlates with a different heart rhythm disturbance. Again, patients can have a variety of different heart rhythm disturbances that can cause their heart rhythm to be irregular, that are not atrial fibrillation. And I will say that those generally tend to be more common. So patients can have extra beats in the top chamber of the heart. Again, we didn't really go into that during this discussion, but those extra beats that occur in the top chamber of the heart, we call those PACs, or premature atrial complexes. And patients can have sort of extra beats that occur in the bottom chamber of the heart, abbreviated PVCs, or premature ventricular complexes. And those extra beats that occur in the top or bottom chamber of the heart can cause the heart rate and the rhythm to be a little irregular. Patients can oftentimes describe them as having a skipped beat. And those we don't consider dangerous. They're actually pretty benign. And most individuals, you monitor them long enough, you'll see that most individuals will have those from time to time. So we don't consider those pathologic, not indicative of any underlying heart disease. As far as if that's what you are feeling when you have a glass of wine or exercise, you feel that prickly sensation, it can't be for sure. The only way to know is to have you wear some sort of rhythm monitor, right? And then just hope that, if you have those symptoms, we can see on the monitor if it correlates with anything abnormal or consists with AFib.
Another one of the cardiologists lately talked about the devices, not only the consumer devices that people can wear, but also how the medical devices have become smaller or maybe easier to wear. Can you talk about that a little?
Is that with reference to, say, like an Apple Watch or like a Galaxy
Right.
Watch?
Yeah. And then
Yeah,
also
so
those I guess for wearing the medical devices that a patient would wear. Um, when trying to see what kind of heart arrhythmias they have.
yeah,
We're all concerned with a Holter monitor and thinking, it's this big old box you wear around off of your shoulder, but they become more sophisticated and of course smaller and easier to wear,
yeah.
I
So
think.
so some of the wearables, I think, they actually have a feature where it'll sort of monitor your rhythm periodically, and then will sometimes alert you if it suspects that you have atrial fibrillation. And again, I think those are nice features. And I will tell you anecdotally, we've had some patients that had those features turned on, and it actually did demonstrate that they did have atrial fibrillation, and so it was accurate for some patients. But again, it is one of those things where you usually have to have the strips recorded, to have a physician or somebody with a medical background sort of adjudicate it, just to make sure that it is in fact abnormal and consistent with atrial fibrillation. Now, there is another type of monitor called a loop recorder. I didn't really talk about that at all during the talk, but it's an implantable monitor. It's about the size of a paper clip, believe it or not. And we implant them underneath the skin. And if patients are suspected of having atrial fibrillation, we can sometimes implant that device. It goes underneath the skin. It has a battery life that lasts anywhere, we say, from about 3 to 5 years. And it'll detect if patients are having atrial fibrillation. So we usually will implant those, particularly in patients if they've had a stroke and we think that they may have some underlying occult atrial fibrillation that hasn't been, objectively detected by any other sort of rhythm monitoring. Then sometimes we'll consider implanting that loop recorder, but that's another device. It's not really wearable, but it's an implantable device that can determine if a patient is having atrial fibrillation. But ultimately, whether it be an implantable monitor like a loop recorder, or a smart device like a smartwatch, like a Galaxy or an Apple Watch, or even a Fitbit, I think can do it as well, or one of those Cardia mobile platforms, you want to make sure that a physician is looking at that to be sure what it is, and make the diagnosis.
All right, thank you. All right, maybe two more questions. One person has a question about amiodarone. How long should one take that? Is
Yeah,
that a,
so
go
yeah,
ahead.
is that like a two-part question? Or
No, that's just the one question. Then
okay.
I've got another question after that.
Yeah, so amiodarone, again, I didn't specifically go into the
Amiodarone.
medications that we use to try to treat atrial fibrillation, but amiodarone is one of the medications that we use to try and get patients back in a normal rhythm. It probably is one of the most effective, if not the most effective rhythm control drug that we have, but it is a medication that can have some long-term side effects associated with chronic use. So patients that are on amiodarone generally have to be monitored a little bit more closely with blood work every so often and with lung function testing every so often, just to make sure that we're not seeing any of those side effects. So as far as how long can somebody be on the medication, um, we don't really have any specific sort of set time limits as far as that medication is concerned. Basically, if patients are being monitored and the testing comes back unremarkable, then we know that patients are okay to continue that medication. Again, anecdotally, I can tell you I've had patients on those medications or medications like amiodarone for years. They've been on it for 7 years and they're doing great. And then all of a sudden in year 8, they start to develop side effects associated with the medication. Or there are other instances where the patient's on it for 3 years and they're doing great. And then year 4, they start to develop side effects associated with the medication. So there's no way to predict if somebody will develop side effects and when they will develop side effects. We just know that the longer you're on that medication, the higher your risk is of developing potential side effects, but that's not to say that you will. So again, we don't really give patients a time limit, but because of the potential side effect profile of that medication, if patients are candidates for other medications, then sometimes it's reasonable to consider those first prior to considering something like amiodarone. But
Okay.
we do consider it safe as long as it's being monitored, and as long as everything comes back unremarkable, patients can continue to stay on that medication long term.
All right. Very good. Yeah, I've got to try looking through here. Let's see. I have a couple questions about if AFib could be, misread or um, let's see, thought to be to be caused by activity. Here's one. My paroxysmal AFib seems to be triggered when I am doing activities with my right shoulder arm, such as using a paint roller, vacuuming my pool, or this past week putting up ceiling tile. Can nerve impingement in my neck or shoulder cause this AFib that comes and goes?
Yeah, so one of the things I'd mentioned is that, right, sort of acute physiologic stress can sometimes trigger atrial fibrillation. So if you have some pain associated with, right, a nerve issue, then sometimes that pain could be a trigger for atrial fibrillation. So that is entirely possible. I will tell you that there are some patients, we say sort of high endurance athletes, can sometimes have an increased signal for developing atrial fibrillation. And so in some circumstances, people that engage in, I wouldn't necessarily say an excessive amount of physical activity, but high endurance athletes can sometimes have an increased risk of developing atrial fibrillation. But that being said, we wouldn't ever tell somebody not to engage in physical activity, for fear that they could develop atrial fibrillation. But much like anything, there's sort of a sweet spot, right? Too much exercise can sometimes be a bad thing, just like too little exercise can be a bad thing. But what I will tell you, and this is what I usually tell my patients, if you are doing something that, sort of positively enriches your life, improves your quality of life, is not detrimental to you or other individuals, then we generally encourage patients to do those things. So again, if you like to work out and go to the gym and you notice that you're having, more episodes of atrial fibrillation associated with that, I would never tell you not to work out. Now, obviously, if you're working out like, 20 hours out of the day, going to the gym, and just really, probably exceeding what most normal individuals would do, then I would tell you to probably cut back. But if you're doing sort of a healthy amount of exercise and you're noticing that you have an increased burden of atrial fibrillation, then generally what I tell folks is we just need to be more aggressive at managing your atrial fibrillation, whether that be, let's start you on a medication, let's consider an ablation procedure so that you can do the things that you enjoy, right? Because I would never tell you to stop doing those things. But as far as activity being associated with it, some patients can report that. We generally see that more so in high endurance athletes. And as far as pain or nerve impingement causing atrial fibrillation, yes, that is a possibility. Again, any acute physiologic stress can make individuals more prone to having episodes.
All right, well, thank you, Dr. George. Those are some great answers. We will wind up this webinar now. And I want to thank Dr. George again for presenting this webinar. And I thank you, our participants, for attending and asking such great questions. We will send everyone an email with a link to this session, and we encourage you to share it with other family members and friends. We will also ask you to fill out a brief survey about this program, and your input will be helpful in planning future webinars. Now, if we didn't get to your question tonight, we will do our best to contact you by the phone number or email address you provided at registration. I do think, though, Dr. George, you answered, I think, all the questions that we had very well. So, and if you're interested in making an appointment with a Franciscan Health cardiologist, you can visit franciscanhealth.org and click on Request an Appointment at the top of the webpage. And remember, you do not need a referral to visit a cardiologist. Now, to listen to more presentations by members of our Franciscan Health medical staff, visit our podcast page at franciscanhealth.org/podcasts. You'll find several podcasts about heart disease and heart disease prevention. So on behalf of everyone at Franciscan Health, thank you for being with us tonight. And Dr. George, thanks again for your presentation. And we wish all of you a good evening. Bye-bye.
Thanks, everybody. Take care.